Okay, we are now live. Good afternoon. Welcome to the Health and Government Operations Committee briefing. This is a virtual committee briefing, so I ask for your patience if we encounter any technical or streaming issues. The briefing is being streamed on the Maryland General Assembly's YouTube channel. Committee members will be muted throughout this briefing. If a member has a question after the full topic presentation, meaning all the panels on that presentation, please use the raise hand function, which is located either underneath the participant list on the right side of your screen or under the reactions bar at the bottom of the screen. I'll call on delegates to ask questions. After I call your name, please wait a moment while staff unmutes your screen. Remember, even though we're meeting on Zoom, please adhere to our usual committee rules of one question and one answer from the panel, not one question and one answer from each individual panelist, as well as keeping your question concise. First, the Health and Government Operations Committee will be briefed by the Department of Health on the implementation of House Bill 1121 from 2020, Maryland Mental Health and Substance Abuse, Substance Disorder Registry and Referral System, followed by information from the Maryland Hospital Association, the Health Services Cost Review Commission, and the Chesapeake Regional System for Our Patients. Presentations will be followed by questions from members. We'll then be briefed on the suicide experience in Maryland by the Department of Health, and we'll hear from our DLS staff on suicide in Maryland rates, best practices for prevention, and recent legislation, followed by information from Behavioral Health System Baltimore on crisis care and suicide prevention. The briefing is scheduled to conclude by 3 p.m. With that, let us turn to the Department of Health. Will start with Dr. Aaliyah Jones, and if each person who's speaking would just introduce yourself before you speak, that would be super. And I'm going to make one last announcement before Dr. Jones speaks, and that is, if you're a member of the HGO committee, I need to see your participation, not an icon of your participation, a photo, an emblem, or a name, but rather your actual participation, meaning your live streaming. Thank you very much. Dr. Jones.
Good afternoon. Can you hear me well?
Very well, thank you.
Great. Thank you. For the record, my name is Dr. Aaliyah Jones, and I am the Deputy Secretary for the Behavioral Health Administration for the Maryland Department of Health. House Bill 1121 was passed during the 2020 session and went into effect in 2021. The Maryland Department of Health was in the process of rolling out a bed registry system in 2019 and ready to sign a contract with a vendor in early 2020. However, we opted to halt the process because it would not meet the spirit of the new legislation. The previous registry did not include a referral system, was not available to all providers, it was a closed system, and did not consider commercial and private payers. The main focus was the public behavioral health space and individuals who only required inpatient services. HB 1121 legislative mandates include a searchable inventory of providers of private and public mental health substance use disorder services, including inpatient, crisis, and outpatient services, a registry that allows providers to update their own registry information, electronic referral system that is available to any health provider in the state, and collaboration with CRISP. The Maryland Department of Health partnered with Do It to conduct a required feasibility study, a copy of which was provided to the committee, in order to determine what is necessary to achieve the aforementioned legislative goals. The study focused on accurately identifying the scope and size of the bed registry and referral IT initiative, including the estimated cost to implement it, identifying appropriate vendors who already have similar platforms in place, and to learn from other states' experiences. And lastly, identifying and highlighting CRISP's role in project implementation. This is a major IT project with an initial cost estimate of approximately $6 million over 2 years. It must be flexible, scalable, have interoperability, and be user-friendly. It must have a searchable inventory of providers and allow self-service updating of registry information by providers. Could we have slide 1, please? Is there a slide that's visible? Can you all see a slide?
Is that the single slide or is?
Yes, that's the
Single
sixth slide.
Okay, and I go to share screen. And that's it. It's this.
Thank you very much. As you can see on the slide, this is an extremely complex project. The platform architecture is organized around 9 critical areas based on their function. These functional areas are designed to tightly integrate with each other, and failure to include any one of these 9 pieces will cause significant limitations to meeting the legislative requirements and will impair usability. The provider icon is meant to represent not just hospitals, and so that's the little hospital, the little building at the bottom right of the screen. This icon is meant to represent not just hospitals, but other facilities and ambulatory providers who might use this application. These providers might or might not have electronic health records onboarded with CRISP. Data submitted by providers about who they are, what services they have, and who their clients are essential to every workflow in this application, either self-reported or interfaced through CRISP. Success of the platform will rely heavily on the frequency, accuracy, and specificity of provider-submitted data, as well as the ability for the provider practices to dedicate staff and other resources to the reporting of this data. This platform is a clinical tool. Its success will be tied to the ability of providers to integrate this tool into their existing workflows. The study looked at similar systems in 5 other states, including the platforms used and lessons learned. Identified pros and cons of 3 potential platforms that the Maryland Department of Health can consider utilizing, which includes one of the vendors, which is going to be used by only one of the Catalyst grantees, GBRICS. CRISP was consulted throughout the feasibility study process, and collaboratively it was decided that it was not the appropriate platform for the entire project. Collaboratively, we are identifying the areas most appropriate to leverage the CRISP platform, focusing specifically on their strength as an information exchange hub, and possible avenues are listed on page 18 of the feasibility study. The feasibility study allowed the Maryland Department of Health to accurately categorize the bed registry and referral platform build-out as a major IT development project as defined in State Finance and Procurement Article Section 3A 301F. DeWitt Deputy Secretary Lance Shine is also on the line and available to answer any questions you may have around this process. It was important to have this project categorized as an MITDP because the legislation states that the creation of the registry and referral program is contingent on funding availability. It is important to request this project be designated as an MITDP in order to ensure funding is available for the lifetime of the project. Funding will not be available until fiscal year 23 for the technical build out. So in the interim, an advisory, we're planning on doing several things. Number 1, an advisory committee has been established, and the committee, and you all have been provided with a full list of members, and will begin meeting regularly to identify and make policy decisions. Number 2, we will begin the hiring process for analysts who can start building the architecture illustrated in the feasibility study. And lastly, stakeholder engagement will begin in a phased approach, similar to the approach taken in early 2020. This is, and actually into 2019 as well. This is arguably the most important work to be done because without stakeholder engagement and buy-in, the registry will not work. As I mentioned previously, the registry and referral system success will be tied to the ability of providers to integrate this tool into their existing workflows. Providers must be on board, willing, and able. They must have staff, access to the internet, and technological capabilities to input bed and outpatient treatment availability in real time. And with that, we'll be open to any questions that you might have. Thank you so much.
Heather, are you next on this panel? Heather Schacht?
Thank you, Chair.
Yeah, I assume each of you knows who's next, and you can just step up and introduce yourself so that I don't have to interject myself, okay?
Sure. For the record, Heather Schacht,
Thanks.
Director of Governmental Affairs with the Department of Health. Dr. Jones was the only one that we had presenting on this matter. Myself and Steve Colby are here for questions.
Thank you for that explanation. I appreciate it. Okay, we will save our questions. We will next hear from the Maryland Hospital Association. Erin.
Thank you, Madam Chair. And Jen, I think I have some slides to walk through. While Jen is pulling those up, for the record, my name is Erin Dorian. I am the Director of Government Affairs and Policy at the Maryland Hospital Association. MHA and our members were supportive of House Bill 1121 and are ready to become users of this system. During the 2020 legislative session, Maryland's hospitals were also supportive of a sister piece of legislation, House Bill 332, sponsored by Delegate Bagnall, to create a model program for crisis stabilization centers. Before I get into what Maryland's hospitals are doing to ensure that all patients are connected to the appropriate level of care, I want to provide a bit of background and context as to why we believe House Bill 1121 and House Bill 332 can work together to help address the behavioral health crisis in the state. I also want to say that while this legislation, when implemented, will help the state move forward, there are additional steps needed to secure the behavioral health workforce and improve access to behavioral health care. Next slide. While the data on this slide is a bit older, it illustrates the high level of psychiatric occupancy in both Maryland's acute care hospitals and specialty psychiatric hospitals across the state. The blue bars show the average daily census, while the line on the top shows the annual staffed bed occupancy. Staffed bed occupancy illustrates the true availability of healthcare services. Without a staff, without a nurse or a doctor or the staff that we need to care for the patient, a bed is just a bed. Maryland's hospitals averaged around 80% staffed bed occupancy over the time shown on these graphs, and we believe that that trend continues into the most recent fiscal years. What I don't have on this slide is the chart from this report that shows the occupancy at the state psychiatric facilities, which hovers around 100%. Due to these high occupancy rate in state facilities, it is extremely difficult for individuals who may need longer-term psychiatric care that was once offered at state facilities to be admitted, unless the patient is court-ordered into treatment. 100% occupancy is not, nor should it be, the goal for hospitals. Given Maryland's high occupancy rates and the stories we all know of long ED stays or inpatient stays due to the inability to discharge, Maryland's hospitals completed 2 studies prior to the COVID-19 pandemic. And if you'll indulge me, I will briefly touch on these results. Next slide. Over a 45-day period in 2019, 29 hospitals throughout the state collected information on every patient who presented in the emergency department with a behavioral health condition. In that time, these hospitals saw almost 5,000 behavioral health patients, with 42% of those patients experiencing a discharge delay. This amounted to over 1,200 additional days patients spent in an emergency department during the 45-day study period, waiting for a transfer to their next level of care. Drawing your attention to the table on the right side of the slide, over half of the additional days were spent in emergency departments were related to the availability and capacity of the facility or program which the patient was referred. Lastly, over half the patients who visited an emergency department during the study period did not need an inpatient stay in the hospital, further illustrating the need for more appropriate alternative destinations to help patients experiencing behavioral health crisis not end up in an emergency department in the first place. Next slide. Maryland's hospitals also completed a study of discharge delays in inpatient beds because bottlenecks in any part of the system will lead to patient delays everywhere. 31 hospitals participated in the study, and a total of 266 patients were delayed during that 90-day period. On average, these patients spent an additional 13 days in the inpatient setting after they were ready for their next level of care. Again, the graph on the right side shows the reasons for these delays. And again, almost 50% of the total delay days were due to capacity issues at the patient's next level of care. Both of these studies were published prior to the 2020 legislative session and contributed to the hospital field's decision to support both House Bill 1121 and House Bill 332. Next slide. House Bill 1121 creates a new tool to improve coordination among providers and across the continuum. In addition to including services beyond the inpatient psychiatric services, as previous attempts at a bed registry focused, House Bill 1121 includes a broad array of providers and making it especially useful for emergency departments. House Bill 1121 also smartly utilizes the CRISP infrastructure. Next slide. The tool envisioned by House Bill 1121, and as you heard from Dr. Jones, will work within existing hospital workflows. It is the goal of every hospital across the state to begin discharge planning at admission. Hospitals employ specialized staff across hospital units to engage with local agencies and post-acute providers. Some hospitals may call these employees discharge coordinators, some call them social workers, some call them behavioral health consultants, but their job is essentially the same, to help facilitate the patient's transition to the next level of care. Early on in the opioid crisis, hospitals implemented SBIRT in every emergency department throughout the state. As part of SBIRT, hospitals employ peer recovery counselors, who are individuals with lived experience that can help a patient in crisis enter treatment. These recovery counselors help facilitate warm handoffs to the next level of care from the emergency department, sometimes physically escorting the patient to their next level of care. And because these are individuals with lived experience, they are better at connecting with a patient who is currently experiencing a psychiatric or an addiction crisis. Lastly, larger hospital systems have set up internal hospital command centers. These can be a centralized staffed office available 24 hours a day with access to a system-wide bed board showing any available bed throughout their facilities. These command centers can also assist in the facilitation of transfers to community providers. While these command centers may not be efficient for smaller and independent hospitals, they help system hospitals manage patient load across facilities. House Bill 1121 requires CRISP to work within these existing workflows and creates a system to help hospitals coordinate between hospitals and work with community providers. As I stated earlier, hospitals are ready to utilize the tool envisioned under House Bill 1121. Setting up the system is an important step in addressing the behavioral health crisis we are facing as a state. However, there needs to be additional investments in our healthcare workforce and quality community behavioral health providers to ensure patients have access to the behavioral health care they need at any level in the system. With that, I am finished with my presentation and I am happy to turn it over to the next presenter.
And that would be Tequila Terry.
Good afternoon, everyone. I think Katie Wunderlich is actually going to start with some opening comments.
I apologize, Madam Chair. I didn't realize we were up next, so I apologize for the delay. I do want to thank the committee and the committee members for holding this hearing on an issue that we all believe is critical to expanding and promoting behavioral health care and access to behavioral health care across the state. I want to commend my colleague Tequila Terry and her team for putting together some grant opportunities that she's going to go through that help to supplement and support the goals of HB 1121. Early on in 2019, we realized success under the total cost of care model really required us to focus on the behavioral health crisis that many Marylanders are facing. And we wanted to dedicate some specific money and grant funding towards that issue. We commend the committee for the passage of 1121, and we do think that the activities that the HSCRC has put together with hospitals and their community partners does help to support and supplement the goals of 1121 by directing additional funding for behavioral health crisis services. And with that, I'll turn it over to Tequila Terry to go through some of the specifics of that program.
Thank you, Katie. Well, good afternoon, everyone. For the record, my name is Tequila Terry. I am a Deputy Director at the Health Services Cost Review Commission. And to Katie's point, I wanted to just give you a brief overview of the program that Katie has been referring to. It's called the Regional Partnership Catalyst Program. And the idea for this program, again, predated the legislation that we're referring to now. It started in 2019, but to Katie's earlier point, it really does align and supports the efforts that we are all interested in to improve the behavioral health infrastructure around the state. So the program is designed really to invest in hospital partnerships with community organizations so that jointly together they can build sustainable programs that ultimately support the population health goals that are required under the total cost of care model. So the concept is that we have earmarked funding to direct to hospitals who are working with community partners to actually implement or expand behavioral health crisis services infrastructure in several regions across the state. So the funding program launched earlier this year, January 1st of 2021, and it's a 5-year program. And during that time, the organizations that have been awarded funding are going to be launching programs that align with the Crisis Now model, which is a set of recommendations, best practices issued by the National Alliance for Suicide Prevention. And it's this idea that there are these building blocks that communities can actually create to increase the infrastructure for behavioral health crisis services. So a part of the model is that communities can work together to create crisis call centers or air traffic control services. And these programs use technology for real-time coordination and high-touch support to individuals and families in crisis. The idea is that it becomes an alternative to 911 or emergency departments for people in crisis, and is used as a way to dispatch, for example, mobile crisis teams to provide information on resources, to help people in securing behavioral health appointments. Another component of the Crisis Now model is the mobile crisis team, community-based mobile crisis team program. And the idea here is that there are teams that can be deployed to do outreach and support to locations where people are experiencing crisis. So it allows for a method to deploy resources to those areas where people are really struggling with issues, crisis, or are in crisis. And then finally, it incorporates the idea of creation of short-term subacute residential crisis stabilization centers. And so the idea is that for individuals who need support and observation, but not an ED hold or a medical inpatient stay, it creates an option for those individuals. And all of these things are wrapped up inside a set of principles and best practices that are a part of the model. So the idea, again, was that the HSCRC created a grant program to enable hospitals and their community partners to work together on implementing those models. We launched an RFP process in 2019 or early 2020, really with 2019, to accept applications from hospitals interested in securing funding. And we were overwhelmed by the number of hospitals that actually expressed interest in doing this. So we made some very tough decisions based on the funding that we had available to be able to award $79.1 million in funding for a 5-year period to 3 organizations that will be working in various regions across the state. So the one that I know you all have heard of, the Greater Baltimore Integrated Crisis System, or GBRICS, will be working in Baltimore City, Baltimore County, Carroll County, Howard County. Totally Linking Care will be working in Prince George's County, and the Tri-County Behavioral Health Engagement, or TRIBE, is going to be on the Eastern Shore in Worcester County, Wycomico County, and Somerset County. And so each of these entities included a vast number of hospitals that came together with community partners, including, local health departments, nonprofit organizations, local employers, faith-based organizations, healthcare providers, academic institutions, social services, local behavioral health authorities. So these groups are working now together across the state with the goal of implementing, again, those elements of the Crisis Now program. And so we have just wrapped up a series of mid-year check-ins with those entities. They have just completed their first 6 months of work. And so they are very busy working to, procure software and technology that will help them in deploying those, mobile teams, hiring resources to be able to work in communities. On the Eastern Shore, they'll be building a crisis stabilization center, doing community outreach. And so, despite what we have seen with the COVID challenges and the effects of the pandemic, these partnerships are continuing to work across the state on these initiatives. And so we very much are in support of the efforts to expand access to behavioral health services. The regional partnerships will help in these 3 regions of the state. We want to make sure they are successful. So we are really trying to make sure that they are aligning very closely to really the goals that we set forth in that 2019 proposal. And we believe they are, in fact, going to support the broader goal of increasing access. So with that being said, I'll stop there and certainly be available to answer any questions when the time comes.
Great.
Thank you. Next, we'll hear from Craig Bem.
I was going to say, I thought I was batting cleanup. Thank you, Madam Chair. Craig Bem, the Executive Director for CRISP, Maryland State Designated Health Information Exchange. I'm sure there are going to be a lot of questions, so I'll be brief. First, I'd like to say that I really appreciate the collaboration with this committee, the department, the HSCRC, and MHA. All of us have had many conversations together to solution this and to work through the technology, and I think they've been really fruitful. As expected, there are clear areas where the HIE can support this framework outlined in House Bill 1121. We provided a lot of input during the feasibility study, and as Dr. Jones said, we do agree that CRISP is not the right entity to kind of build out this fully envisioned system. That said, we are prepared to leverage a number of our tools and resources for things like the data integrations. That's certainly both in our name, but what we do. For workflow optimization, there's a lot of work we've done over the years to do things like put specific pieces of data at the workflow of hospital providers and community providers. And I think the fewer things that people log into, the more likely they are to be used. And so that's a very clear area of collaboration. And I'd also say that again, thanks to this committee, there's a lot of patient consent work happening. And so the idea that patients can capture consent, provide authorization, and share their sensitive data with their healthcare data is a really important aspect that I think we can bring to the table. Maybe I'll just conclude by saying, I think all of us are very aware that much of the need that patients have cannot be solved by technology alone, but we're certainly going to do the best we can. And so with that, I'll turn it back over.
Thank you. That concludes the input from our people who are briefing. And now I'm ready to look for hands in the panel. And I see that we're going to start with Delegate Lewis Young.
Thank you, Madam Chair. I'd like to address my question to someone in the Department of Health that deals with Medicaid policy. This is a bed access issue. It's my understanding that any facility with an IMD designation, institution for medical disease, must make 5 attempts to admit behavioral health patients to acute care hospitals prior to any call for inpatient admission. Given that this policy to inpatient admission delays for our most vulnerable, are there any efforts to relook this policy?
I'm looking to the department for someone to answer this question.
So this is Dr. Jones. So the process is that if someone's in an acute hospital, then before they can refer them to an IMD, they have to look for a placement in another acute hospital before they can make that transfer or make that referral. That is because we don't have the funding for patients being in IMD facilities that we used to. However, we did apply for a waiver, which we are hoping to get, which should go into effect in January. And then that will remove that as a necessity or barrier or delay or cause for delay to transfer people to, or at least to refer people to the IMD facilities. Just because they're referred doesn't necessarily mean that they will be able to get in either. However, we will be able to refer them more quickly starting in January.
Thank you.
You're very welcome.
Delegate Cullison.
Thank you, Madam Chair, and thanks to all the providers. I think what I'm looking for is just an affirmation from the department that we will be extremely diligent in making sure that resources are used to their maximum potential. My concern is that we're going to have duplication of efforts, that there's going to be, the coordination will be not as careful as it needs to be. And so we won't be using the dollars that we are spending in the way that's the most useful. So, I mean, I saw the chart and I understand the intent, but I guess how can we assure that the coordination of efforts, because you've got a lot of different parties here. You've got, the hospitals, you've got, community organizations and partnerships, the department, I'm sure there are others I'm missing, that all have to come in together on the same program to make sure that we have something that actually meets this need. So it's, I guess, looking for that coordination concept.
Yeah, thank you very much for that, Delegate Cullison. And I think the important thing and one of the main goals of the department, and we are certainly, dedicated to making sure that the resources, the limited resources that we have are used to the full capacity. And I think that's where our advisory committee comes in. There are several members and it includes internal and external partners, and we can I'll provide the full list to the committee. It should be posted onto the state archives page today or tomorrow morning. But I mean, it's internal to MDH, and then we have representatives from private insurance, mental health providers, the MIA, the SUD providers, private insurance, minority-owned insurance. We have the Hospital Association, Do It. I mean, and the list goes on. So we have really made sure that our advisory committee, or we've tried to make sure that it is all encompassing to ensure that there's that, continuity across all providers.
Great. Thank you, Heather. Thank you, Madam Chair.
Next on our list is the Vice Chairman, Delegate Melnick.
Thank you, Chairman. Good afternoon. I want to start by saying, thank you for the department for doing the study and for going back to the drawing board after 2019 to do this right. I have a couple of questions. First, how long did you say this comprehensive system will take to develop? Who would answer it?
Dr. Jones.
Myself off mute. This is Steve Colby, Department of Information Technology for the Maryland Department of Health. Thank you, Delegate, for the Madam Co-Chair for the question. The information that we had in the study dealt mainly with the initial planning stages of the project. We're expecting full implementation by March 31, 2024. But I would note that number is subject to further revision based on our fully fleshing out of the requirements.
So it's fair to say that it could take anywhere from 3 to even 4 or 5 years, right?
Yes, I think IT development typically operates in an agile development model. For a project like this, we could start to see meaningful value sooner. We wouldn't develop the project and then deliver everything at the end of that 3 or 4 years. We would begin to develop and deliver value on an incremental basis.
And I guess my question to the department regarding the funding is there's a lot of money coming from the federal government and there's a lot of excess money. Have you looked to see if some of that money can be used for this project?
I'll turn that over to Dr. Jones for an answer.
Sorry. Yes, we certainly have. However, that's not going to be sustainable.
Okay. So the other question I have, this is great that you're working on it. However, what happened to that 14-year-old that I waited, 15 hours at the hospital with? All the calls that we get from our constituent where they're waiting, if you have a child that has autism, they spend 3 months in the ER. Sometimes they spend, I have received calls, children that have been there 7 weeks. And this is often, and is throughout the whole state of Maryland. So this question goes, and I like to hear from everyone, if I may, Madam, if I may, Chairman, people that presented. I like to hear from the Department of Health, the Hospital Association, the Health Service Cost Review Commission. I like to hear what can we do during those 3-5 years that it's going to take to develop this regarding, the inpatient beds, the crisis support, payment reimbursement. What can be done for the people in Maryland, especially given the crisis that we have with behavioral health, so that they're not waiting all those hours. I saw the presentation by the department. I was not surprised. In the hospital, what can you put in place to make sure that we are alleviating this position? I know that in the hospital, in the bill on page 4, line 29, I make sure to put, because I attended all the meetings, that each hospital shall, is not discretionary, ensure the availability of staff to identify appropriate and available services for patients in the hospital who are in need of mental health or substance use disorder services, and to assist the patient in assessing the services. So when we put that language and we compromise, we discuss hospitals, hiring additional staff. And I know that the hospitals have received significant money. You have excess revenue for reinvestments, hundreds of millions of dollars that are going to be targeted for reinvestment. What can you tell this committee that what steps will you take to make sure while this system is developed that people are not waiting for months in the ER?
Thank you very much for that question, Vice Chair. We certainly have are always concerned about care, and particularly behavioral health care for those in the community. And the development of this platform certainly is not going to put on hold any of the other initiatives. And we have numerous other initiatives that we are trying to bring to bear to resolve these sorts of challenges. So one of the issues is when you're talking about, one of the big things that we're doing is looking at our crisis services system in general. If we can do a better job of managing people who are in crisis in the community, then that's one way to help prevent people from going to the hospital. One of the things that that Erin pointed out previously is of the many people who go to the emergency departments, very few of them are actually admitted to the hospital. About 30% typically, 30 to 40% are admitted to the hospital, which means that typically means that 60 to 70% of those people didn't need to go to an emergency department in order to receive care. Their care could have been delivered in some other way. And so we're looking at the partnership with GBRICS to bring on the crisis stabilization centers, the state with the master facilities plan, creating 3 or 4 other crisis centers throughout the state at a minimum. Also looking at how we are addressing children and looking at how we are completely re-envisioning how we manage crises for children and doing that more at the home as opposed to having to come to the hospital for care because it's not an appropriate place for them to be. Also looking at how we leverage our federal dollars for federal funding. We did apply for the mobile crisis planning grant so that we can do more with mobile crisis in the state of Maryland. So we're looking at lots of different ways and appropriate ways to better address the patients who are people or constituents who are in the community who potentially could be at crisis. And when they do get to crisis, to make sure that they are going to the places where they need to be, which usually is not an emergency department. It's not typically the best place for someone to be in a psychiatric crisis. And while we're still doing the platform as well, but that's not going to stop us doing taking the other steps that are necessary to address this issue. And I can turn it over to someone else from the panel unless you wanted to ask another question.
Yeah, if I would like to hear from Erin, please, Ms. Dorian, regarding, I know that the hospital have this revenue for reinvestment. And I know that you went through the different people that are at the hospital, like social workers and so forth. Tell me, are you planning on hiring additional people to handle this crisis, the people that are waiting at the hospitals, because it's needed?
So thank you, Madam Vice Chair, and thank you for giving us the opportunity to be here today. I can't speak directly to exactly what the revenue for reinvestment can be spent on, and I will come back with some answers about that. I will say, that hospitals have hired specialized staff that understand the intricacies of, the needs, the complex needs of these patients that can help navigate the complex systems at the local level that are in place. For some of these kids that you've talked about, they may be connected to multiple local departments like the Department of Social Services or the department of their local education agency. So these specialized staff understand, the intricacies of that process as well. As quite frankly, understanding, how these providers can get paid, whether they are a Medicaid patient or whether they have private insurance and the provider accepts their private insurance. So we do have hospital staff, and we need to have hospital staff that can understand all of those complexities. We are in a staffing crisis. We're in a staffing crisis across for every type of provider and hospital worker that we need. And so, to the extent that hospitals will use their revenue for reinvestment for hiring staff, if they are allowed, I know that they will do that. Some of the problem is these staff just simply do not exist. You know, we can't find social workers, we can't find nurses, we can't find environmental service workers, quite frankly. So I think in the short term, if there is one thing that this committee could focus on for the next few years, and I know that this committee can focus on more than just one thing, I would say we need to focus on our healthcare workforce crisis, because that's going to be felt for behavioral health patients. It's going to be felt for patients with any kind of condition, somatic condition, behavioral health condition, anything.
I think that, you know, the committee, and I won't speak for the chairman, who's the leader of the committee, you know, the committee will be looking at that and other issues, but the hospitals, you know, you have the resources, you know, it wasn't so bad for you, thank God. During COVID, it wasn't as bad as we expected it. So you do have resources and you have money from the federal government. So we're asking you to be creative in creating programs, you know, to create a pipeline of workers, to give them incentives, which you can do like other jurisdictions are doing. When I was at the hospital with that 14-year-old, the nurse was the one that was making the calls. And she, you know, will go see another patient, then come back and make a call and call even Virginia to find a bed. So I understand what you're saying, but you must be creative and think outside the box. And I think what I would like to suggest, if I may, Chairman, is that you put together the following group, and that is the HSCRC, the Department of Health, CRISP, maybe Lori Doyle, someone from the behavioral care, healthcare providers, and the hospital, to come together to look at, you know, what else should you be doing? So it's not piecemeal, whether it's the payment reimbursement, whether it's the physical infrastructure, what can we do to find these beds? And the HSCRC can play a big role here. And I like that, because I like for you to put that together, because we can't wait 3 to 5 years for this registry to be developed, because you still have the problems of the bed. And I need you to think outside the box, to come together creatively and try to find a solution meanwhile. So I am asking the Department of Health, the hospital, Health Service Cost Review Commission, CRISP, and someone from behavioral health to come together and put an informal group to try to figure out what else can you do. Now, who can lead this? Should I make a suggestion? The HSCRC, can you please lead this work group?
Yes, we'd be happy to continue to have conversations. I would point out, I think a lot of the need is on the other levels of care, as Ms. Dorian and others have mentioned, that the fact that, yes, we need to make sure we have available inpatient beds, but we also really need to make sure we have outpatient crisis center and other beds. So we'd be happy to lead the conversation, to continue this very important work, to figure out how we can coordinate and expand the delivery system. I do have a lot of faith and hope in the work that GBRICS is doing and others are doing through our regional partnership grant program. Those fundings are really getting started this year. I'm really hopeful that there will be some immediate impact on patients, on residents in Maryland that need crisis care, that we can intervene. So I'm hopeful that we have some initiatives underway, but I'd be happy to continue to lead the conversation with my other colleagues.
That would be great. And if you can give us an update, please, in about a month of how those conversations are going, that would be great. And just to be clear, I like you to look at, the bed situation, the payment reimbursement. I want you to think about the monies that, people have now from the federal government, extra money, and reinvesting some of that. And I like you to please be creative. And I thank you I know I put you on the spot, but thank you for accepting to take the lead.
Absolutely.
Thank you, Chairman.
Welcome. Next on my list is Delegate Rosenberg.
Thank you, Madam Chair. My question was going to be about what steps are next steps are necessary, whether they are legislative or budgetary, but I think that issue has been more than addressed by the Vice Chair's question. The only question I might pose is to an advocate who has not responded to the questions from the Vice Chair, if there is anything one of the advocates would wish to add, a discussion about next steps and what needs to be included in that study.
There is no advocate in this panel,
Okay.
so that will have to be done offline.
Okay. Thank you, Madam Chair.
Thank you. With that, I'm going to call on Delegate Hill next.
Thank you, Madam Chair. So first of all, thank you all for being here. I really want to thank the Vice Chair for her, very insightful comments and directives. And so I want to make just a quick comment and have one question. The comment is, I think that you need to look at your statistics a little differently when you talk about the 3% who experienced delay. Use the denominator of all the people presenting in the hospital for behavioral health treatment, when you probably, I believe, ought to be looking at that denominator as being those people who required discharge planning. In other words, if people are going home after coming in for a crisis and they don't have to be referred, they shouldn't be in the denominator because they're not part of people who might receive a delay. So the question is, and it's apropos of everything that's been said, including Dr. Jones's comments, what efforts are you all taking or suggesting be taken to better ascertain where the behavioral health providers, from social workers, nurse practitioners, psychiatrists, psychologists, what it's going to take to get them to do more of that community work, how we can support them. I know that a lot of the committees and the work groups include the clinics, but I hear all the time for providers who are very frustrated with the way the system's working. And I'm actually sorry there aren't providers at this presentation today. So how are we going about actually engaging the people who can do the community care that to so critically build up?
Who are you asking the question of, Delegate Hill?
It can be whoever, the department, whoever. I just need to know how we're going to engage all this.
Okay, let's go to Dr. Jones, since she represents the department and I think is taking the lead on this. Dr. Jones, are you there?
I am. I'm sorry. Please excuse me. So engaging the provider workforce to do more community. I guess I don't think I understand the question.
Yeah. So if we're saying that we would have fewer ER visits if there was more service being provided in the community.
Okay.
Less of a problem with delays in discharging. If places to go to, and sometimes that doesn't mean a bed. It means someone who'll say, I will take this patient on. And we know that there are many providers who don't want to accept insurance. And so we have them as not available. We have problems with even keeping an accurate list of providers who are available, so that when patients try and find a provider, they can't find them, or they go through multiple phone calls to find who even accepts their insurance or is available, and et cetera. We've got problems with that aspect. And I'd like to know, because I don't see how this big picture piece that's really wonderful is going to work if we can't engage the providers in Maryland who trained and want to provide the service that we need.
Okay, I understand your question. Thank you so much for clarifying. So I think there's a couple of challenges embedded in your concern. Number one is with regards to the lack of availability of providers who take private insurance. And certainly there's a lot of work that's going on around mental health parity, making sure that the private insurance companies are adequately resourced so that when people do have behavioral health needs, that they actually can access those resources. And I know that the MIA is doing a lot of work on that front. The other thing that we're doing is that we are trying to do a better job in terms of communication and helping people to understand that when they have a need, and certainly those who are using the public behavioral health system, but even those who aren't, that they can use their local behavioral health systems managers to help identify resources in their respective communities. You're shaking your head. No, that's not an option.
No, it's a great option. It's just not
Okay.
working very well.
Well, and I think that just because it's not working well doesn't mean that it's something that we should abandon, that we shouldn't work harder to improve. I know that throughout COVID, you know, we have used the locals as a glue to help share information with their local communities, every local community being different and having different needs throughout the COVID experience. And so I think that providers have a much better finger on the pulse of the locals have a much better finger on the pulse of the providers in their respective areas now than what they probably did before, because the local providers have been leaning on their local behavioral health systems managers for things like PPE and to know, you know, what they can and cannot do. And so hopefully, I mean, this presents an opportunity for us to do a better job to continue those intense collaborations and communications with the local providers than what we had before. Even at the level of the Behavioral Health Administration, since the beginning of the pandemic, we have had weekly to bi-weekly conversations with different types of provider groups. And we have not stopped doing that even during the times when the COVID numbers were lower and people knew how to function and it was kind of status quo. We still continue to keep those intense conversations going. And we don't have any intention to let up, because it's a great way to continue to share information and to continue to work with one another and to improve the system and know what people need in order for us to operate. So I do understand what you're saying. So I think that there's an opportunity for us here to continue that work. But what we also have, though, is that there is that workforce shortage issue also, and I'm sure you understand that as well. Is that even if everybody comes into the system, and this is not particular to Maryland, it's the entire country, if everybody who has behavioral health needs looks to get the supports that they need and that they deserve to have, the truth of the matter is that the workforce is not there, and that's not just here. We have probably one of the best workforces in the country, and we still don't have enough providers. And so we do have to think creatively about other ways to deliver behavioral health systems and supports and services that are less dependent on an interpersonal interaction, particularly for those who might not need interpersonal interactions and can use a lower or a different standard. Or how do we grow other types of providers in the community so that we can leverage and make sure that those who are the most impaired have access to the most specialized care, treatment, and services, and those who are better able to utilize less intensive resources have access to those resources as well. And so we're certainly thinking about what do we do, how do we do it. We certainly are looking at at some technologies, looking at workforce development to try to address what we know is a problem that's only going to grow in light of the fact that 30% of people who have COVID are going to have some sort of behavioral health sequelae. So we're definitely being mindful of all of that. Thank you for your question.
Thank you. I appreciate your efforts and your commitment and the work. Thank you.
Thank you.
So, Delegate Johnson. Delegate Johnson.
Thank
are
you, Madam
there?
Chair.
Great.
Thank you, Madam Chair. Can you hear me?
Yes.
And thank you all for coming to present to us today and speak with us about these issues. Dr. Jones, you talked previously about developing more crisis centers around the state. We have many crisis centers around the state now that are having funding issues. Are there any plans to use some funding to work with the existing centers that we already have? And these centers already have staffing, they have beds, they have youth areas as well as adult areas. So is that a possibility that we could do a better job working with existing crisis centers while we're building out this 3 to 5 year program?
Thank you for your question, Delegate.
Anybody who wants to answer?
Thank you for your question, Delegate. There is no, as I said before, we will continue to advance the behavioral health system in every other way that we can, as we are also working in parallel to bring this referral platform on board, which of course includes continuing to work with and provide supports that we have available to our crisis beds. It's certainly not our plan to abandon or to decrease the number of crisis beds that we have. We are, if anything, we need to continue to grow that service line. And so we are certainly using our federal dollars to that end. I'm using our state allocated resources also to support that type of programming as well. And we have a state planning grant that we've applied for through Medicaid, CMS, to help us to look at what is the right size, what's the need that we have in the state of Maryland, so that we can have a target for how many beds that we need for crisis services through our COVID relief dollars. We're using some of our dollars to help us to answer that question as well. So we follow very closely the crisis bed situation. Our goal certainly is not to turn away from any providers that are already there. We want to provide support to the providers that are there. When we have had state dollars that have come in through the state relief grant that the governor made available, we made dollars available to residential crisis providers to help with losses that they had incurred during the COVID pandemic. So we are fully committed to our providers in the community who are currently already providing services, in addition to those that are coming on board.
Thank you.
Very welcome.
Okay, I am going to use the chairman's prerogative to not ask questions, but rather to make my comments. I'm totally disheartened. The thank yous from my committee were very polite and I'm sure heartfelt. And I'm sure everybody is working, but we're failing. I'm thinking about the Optum system that's not paying mental health providers in a timely fashion. That's the department. I'm thinking about the telehealth rules that I believe have been rolled back to reimburse less for telehealth now. And the mental health community is concerned about that. We're talking about not having providers, and here we are with extra money because of the crisis, and we're not using it to fund the things that immediately need funding. And it's not like this is a surprise. People like me who are not doctors, who are not mental health professionals, we've been reading for a year that there was a crisis in mental health that had been exacerbated by COVID. And then for the last 6 or 8 months, we've been reading that the crisis is now being exacerbated further by the fact that not only was there a crisis caused by people having to change their lives and stay in, but there's a sort of a bounce back process that people going back into the world are now suffering yet another trigger to cause them problems. The fact that this is taking so long, not only the bed registry, but everything else that the department seems to be not resolving. Maybe you're making slow progress, but at the same time, you're making things worse, simply put. So that's going to be my message to you today. My message is also that we need to do a much better job of communicating to hospitals about providers that exist that are current. And I think the health department could have some role in that. And I certainly think the hospital association could have some role in that. And I also think the HSCRC needs to take a role in this, because this is about our total cost of care waiver. If we don't get this right, and if we wait 7 years to get this right, that waiver is going to be gone. And that's going to all be not on this administration, because they won't be here in 7 years. And I think they're very mindful of that. But they've been here for 7 years now. And we are not doing what we need to be doing. The legislature can bring this to the public. The legislature can pass some amount of laws, but when it takes 5 to 7 years to implement a law, Something is going wrong. Maybe it's because the department doesn't participate in our hearing process. They prefer to wait until after we pass a bill before they make comments. If we had had more input from the department during the process on this bill, maybe we could have made it work faster. I can't say that we could have, but I'd like to think we could have. So that's my comment as the chair of this committee that I shall leave you with. And with that, we'll end the part of the briefing that is on the mental health and substance use disorder registry and referral system. And we will move on to part 2, which is suicide experience in Maryland. With that, we'll start with Dr. Aaliyah Jones in our first panel.
Thank you. Good afternoon once again. For the record, my name is Dr. Aaliyah Jones, and I am the Deputy Secretary of the Behavioral Health Administration for the Maryland Department of Health. Can we have slide 2, please? Thank you. Oh, sorry. Thank you very much. Slide 2, please. As of 2019, Maryland had the 4th lowest age-adjusted suicide rate in the country, or 10.29 suicides per every 100,000 Marylanders. Maryland's suicide rate is lower than the 2019 national average, which is 13.93 suicides per every 100,000 Americans. State age-adjusted suicide rates have not been calculated for subsequent years, and 2019 is the most recent data available from the CDC. However, in spite of all these numbers, research does suggest that Maryland's suicide rate is underreported due to the number of deaths that are classified as undetermined. Next slide, please. Please keep in mind that these analyses are preliminary and subject to change as additional information is received and death investigations are completed. Although official rates have not been calculated as of yet, if you look at the left table, preliminary suicide counts are available through the Maryland Office of the Chief Medical Examiner. We opted to provide this information, even though it is preliminary, to help show the early analysis trends requested by the committee. The table on the left side of the screen compares suicide counts year to date in the first 6 months of the year for the past 5 years. With the understanding that the 2021 data are subject to change, our preliminary analysis shows that year-to-date suicide counts are consistent with previous years, which does not indicate an overall increase in suicides in Maryland. However, we are seeing changes in specific age ranges. The count of suicides of those within the ages of 18 to 25 years increased by 80% from the first half of 2020 to 2021, while those aged 26 and over showed a 16% decrease and also represent the larger number of suicides. The data, when broken out by gender and age groups for under 17 and 18 to 25, shows an increase in the number of females under the age of 17, female suicides. This preliminary increase from 20 to 2021 was 50%, but it should be noted that the low overall number attributed to that large change in percentage. For females in the 18 to 25 year age category, they had minor plus or 1 minus fluctuations year over year. In January through June of 2021, males accounted for 84% of suicides in the 18 to 25 age group, And this is consistent as historically males make up 76 to 86% of all suicides in this age category. If you were to look at the right table, for a direct comparison, we looked at the first 6 months or January to June of each of the past 5 calendar years. The number of suicides and intentional self-harm emergency department visits in the first half of each calendar year increased by 47% from calendar year 2017 through to 2021. From calendar year 17 to calendar year 18, there was a 19.4% increase. Calendar year 18 to 19, there was a 15% increase. And for fiscal year 19 to 20, a 21% decrease. And from fiscal year 20 to 21, a 35% increase. The first half of calendar year 2021 had the highest rates of emergency department utilization for suicidal thoughts and suicide attempts across all age categories during the time periods analyzed. We can't determine when someone comes into the emergency department by what we can extract if they were there just for suicidal thought versus suicide attempt. So that's why I say them both together. The youngest population, aged 0 to 17, and those aged 35 to 54, make up the largest groups of suicide attempts coming through Maryland emergency departments. They make up 25 to 28% for those who are 0 to 17, and 26 to 27% for those who are 35 to 54. The age group that consistently is experiencing the greatest growth in suicide attempts and emergency department visits are older adults aged 65 and older, which saw a 91% increase for the first half of calendar year 2018 through 2021. Individuals aged 0 to 17 had a 15% growth, and individuals 18 to 24 had a 30% increase during the same time period. For the first 6 months of 2017 through 2020, there were more male suicide attempts than female, and this has changed in 2021. Female suicide attempts have increased 49%.
May I stop you for a moment?
Sure.
Is there more, are there more charts that are not being shown? Is that our staff that's not showing them, or is
No. There's only one more, and I haven't gone to that one just yet.
Because I'm hearing a lot of data and it's not in front of me. Is that accurate?
That's correct. That's correct.
Thank you.
Yes. For the first 6 months of 2017 through 2020, there were more male suicide attempts than female. And again, I was saying that the female suicide attempts had an increase since 2020, and they actually surpassed male suicide attempts. Females comprised 53% of all suicide attempt emergency department visits in 2021, or so far in 2021. And during the first 6 months of each of the last 5 years, white individuals made up the majority of suicide attempts that came through the emergency department at 52 to 53%. In 20 to 21, there was an increase of 35% in both whites and in Blacks into the emergency department for suicidal ideation and attempts. Next slide, please. Looking at the historical suicide data from the past decade, discounting for 2020 and 2021, which are not yet complete as some death investigations are still pending, the count of suicides for those aged 25 and under, which is the blue line, show a range from a low of 64 in 2015 to a high of 93 in 2018. And for adults 26 and older, which is the orange line, there's been a steady increase each year from 2015, with the highest count being in 2019, with 571 adult suicides. And adults historically make up 85 to 88% of all suicides in the state. Next slide, please. So in response to the changes that we are seeing with regards to suicidality, and we have been working on suicide as a state for many years now, and I think that that's reflected in the fact that we have the 4th lowest suicide rate in the nation. We do have many partnerships that are continuing to look at suicide in the state of Maryland. We have our suicide surveillance group, which is led by the Office of Suicide Prevention. We have suicide prevention experts in our state that convene monthly to review data and develop recommendations for action. This group has identified youth and young adult suicides as a key issue and is continuing to monitor that data on a regular basis. We have a child fatality review group that is in collaboration with the Office of Suicide Prevention and Suicide Surveillance Group. And the state's child fatality review is currently working on a variety of suicide prevention materials for families with a focus on cultural relevance. The CFR is also an essential source of data and recommendations for the local level. We are in partnership with the Maryland State Department of Education, and we know that they have had significant funding that's been secured for youth mental health and suicide prevention, and we meet with them on a very regular basis to continue to partner with them and develop ways of using those resources to better reach the children in our schools. We have training opportunities for ASK training. The Office of Suicide Prevention recently offered and trained clinicians in assessing for suicide in kids, which is what ASK stands for. It's a training that prepares people who work regularly with young children ages 5 to 9 to address suicidal thoughts or behaviors. And the office intends to offer several sessions in the coming fiscal year as well. And then we're also doing a lot around messaging to help make sure that people are aware of resources to turn to if they're having suicidal thoughts, and also to try to address the stigma that's associated with having suicidal thoughts. And so that's what the Stories of Hope social media campaign is. It's to raise the voices of those with lived experience of suicide or a suicide loss. The campaign will help reduce stigma about suicide and encourage help-seeking behaviors. And it will include both written and video submissions, which will allow for a broader reach. That's a campaign that's currently underway. And then also we have youth and young adult champions that we have identified through the Office of Suicide Prevention that we're hoping to leverage our existing youth councils to build new connections with young people, particularly those who are interested in mental health and social media messaging. And outreach has already begun to has been underway to identify our young ambassadors to help us address suicidality in our youth population. And with that, I'll end my comments, and then I guess you turn back over to you.
Thank you. We're going to move to Andrew Garrison, Senior Policy Analyst, Department of Legislative Services, and Amber Gundlach for their presentation.
Thank you, Madam Chair. We have some slides for you all as well. We will also be touching on some of the data and rates, similar to what the department showed, but also including some data from the CDC and local crisis response. And then my colleague Amber will also be talking about some best practices towards prevention and legislation that you all passed. So we can go to the next slide, the next one, please. Thank you. So here, this is from the folks behavioral health system of Baltimore who will be speaking after me, but this is looking at some of the recent data that we have on the Here to Help hotline, which is a crisis response line. And what you see, of course, is that in the early stages of the pandemic, the call volume to this crisis response line did really increase. And while it has slowed down a little bit in subsequent months, it is still not yet recovered to those levels that we have seen pre-pandemic. On the next slide, we have data here from the, next slide, there we go. We have data here from the CDC, and we have two different CDC measures. And this is what we have that goes into 2020. So again, trying to look at as much of what the pandemic's impact may or may not have been on suicide rates here in Maryland and nationwide. We have two different measures that we're presenting, and we have two sets of measures. So we have Maryland towards the bottom of the chart, and then we have the nationwide rates right above that. The dotted lines, those are going to be a rolling calendar year. So when each quarter ends, what that suicide rate was for the previous 12 months. And then the solid lines, the one that's a little bit more erratic, those are the 3 months for that particular quarter, and then having that rate being annualized. And so a few things to take away from this slide. First is that Maryland, while it does generally track with the nation, it is always consistently lower than the nation. And that is consistent with Dr. Jones said, that Maryland is one of the lower, the states with one of the lowest suicide rates in the nation. And that also, we do notice in Q2 of 2020, where we would sort of consider the beginning of the pandemic, a modest increase in that rolling 3-month rate, particularly when you compare that to the prior Q2. And it does also show some seasonality that we experience when we're looking at those quarterly rates. The next slide, we are still looking at the Centers for Disease Control data. Here we took that Q3 data, that 2020, and looked just at that last previous 12-month period. So this is the most recent data that we could find from a nationwide level. And we wanted to put Maryland in context with the nation, not only from a nationwide average, but how we and some of our neighbors do compare overall. So what we have in front of you here is an interpretation of a map of the United States. You see Maryland sort of towards the middle there, next to Delaware and above DC. And still, when looking at this measure, we are 46th or the 4th lowest. And you do also see that the states that are traditionally the highest are the more rural states, those Mountain West states, lower population. And Maryland is, again, lower, and most of the Eastern Seaboard is also traditionally lower as well. On the next slide, we took the same interpretation and we applied it to the state of Maryland. One thing I do want to note here, although the department was able to pull some more recent data, what DLS is using is that vital statistics report from 2019. We did talk to the folks at Biostatistics, and that full report isn't probably going to be released until later this year for calendar year 2020. So we are right now looking at 2019 data, but we thought this would still be helpful to share to sort of foreground some of the trends that we're seeing in suicide rates prior to the pandemic. And so here, looking at this geographic variation, what we see in the 2019 data as a statewide average of 10.8 suicide deaths per 100,000 population. And we can kind of look at some similar patterns that maybe we saw on the national level as well, with some higher rates above that statewide average in our more rural areas. I would also like to note, when we are looking at this data, we are looking at a fairly small number of suicide fatalities, particularly in some of our more rural jurisdictions. And so I would caution there's certainly some volatility in this, particularly we're going to be looking at it year over year, but it would be interesting when that 2020 data is available to draw those comparisons there as well. The next slide, and Dr. Jones did also mention this as well, but there is a pretty substantial gender variation, particularly when it comes to suicide fatalities. Again, in 2019, men in the state of Maryland made up 80% of the suicide deaths. And in particular, white men made up nearly 60% of the total suicide fatalities that we saw in the state. Also, when the numbers that we're showing here are the total numbers of fatalities in 2019, but even when we apply this to a rate basis, again, like the department mentioned, white men and non-Hispanic white as a group in particular does traditionally have a higher rate than some other subgroups. On our next slide, we are simply putting together a table where we have the age rate, again, for 2019 with the total fatalities listed. And as Dr. Jones in the department slide also noted, that from a younger demographic, it is lower than it is sort of for the Marylanders who are in later and middle age population. And my last slide for you all before handing it over to Amber is early on in the pandemic, there was a lot of academic scholars who posited the risk factors that COVID-19 may be presenting that also could contribute to suicide. And before we really dive into this, I do want to caution that, of course, suicide is a really complex issue, and there's never going to be any one particular factor or cause of an individual suicide or suicide attempt. But some things that were highlighted in a April 2020 Journal of American Medicine article included economic stress, particularly being associated with higher rates of suicide. Of course, the pandemic did cause a lot of economic hardships and layoffs, particularly earlier on. Social isolation, as well as any sort of detachment from community organizations or religious ceremonies may have also been associated as a risk factor. Any barriers to treatment that occurred during the pandemic could also be considered. And then the last bullet there is firearm sales. There was an increase in firearm sales during the pandemic. Again, when this was published, it was still fairly early on. But I do have a note there that in Maryland, traditionally, roughly 40% of our suicide fatalities involved a firearm. That's pretty consistent over the last 5 years of complete data that we have, so 2019 going backwards. Now I will turn it over to Amber, who again will discuss some best practices for prevention.
Thank you, Andrew. Next slide, please. So I'm going to be going over some best practices for suicide prevention. This chart is from the CDC. It's a list of strategies and various approaches that can be used for comprehensive suicide prevention across multiple settings. We start with just strengthening economic supports in general, which includes improving financial security, such as improving benefit programs. You also want to ensure housing stabilization. So examples of programs that do that are the HUD's Neighborhood Stabilization Program, which helps provide emergency assistance to keep people on their homes, but also just the moratorium on evictions to help during the pandemic, which helped to ensure some housing stabilization. Strengthening access to and delivery of care. So this is ensuring health insurance coverage, which was also talked about in the prior presentations for mental health conditions. So really the key to that is mental health parity laws, making sure that you can have insurance coverage and get the mental health coverage you need. And then increasing provider access. Really the key here is the expanding access to telehealth for both behavioral health providers and primary care providers, to make sure people are having those needs met. Creating protective environments, which includes reducing access to lethal means among persons at risk, which could include intervening at suicide hotspots, gun control, things of that nature. Changes in organizational policies and culture and community-based policies that reduce excessive alcohol use are also in general part of creating those protective environments. Also promoting connectedness, again, connectedness amongst people, which is what Andrew covered, where people were separated, they felt disconnected during the pandemic. So continuing to promote this now that we're hopefully starting to maybe come out the other side through community engagement activities and peer norm groups. And then specific to addressing people at risk of suicide, you have your Gatekeeper trainings, which include things like the ASK training that Dr. Jones, I know, spoke about. There's also all kinds of different other trainings. There's what's called the ASSIST training, which is Applied Suicide Intervention Skills training, which is a workshop to provide suicide first aid to people in the general community, family, friends, community members, as well as providers, to make sure we can identify and get people the support they need. Of course, crisis intervention. So you have your suicide prevention hotlines, both the national line, which is rolling out now and is set to complete by July of 2022. And then your local crisis lines, such as Maryland's 211 Press 1, to help meet people where they are. You also have treatment for people at risk of suicide. There are a number of different treatment programs that work for those that are at risk of suicide. I won't go over all of them now, but if you're interested, I can give you that information. And then your treatment to prevent reattempts. So if you have an emergency department visit, you need follow-up visits. You want active follow-up care for anyone that has sought treatment for an attempted suicide. And then following up also with cognitive behavioral therapy and other types of prevention therapies. And then lastly, lessening harms and prevent future risk. So you have your post-vention, which is basically your bereavement supports for people who have lost someone to suicide and reaching out to make sure they're not affected by suicide again. And then safe reporting on suicide and messaging about suicide to the communities. I've also broken out, next slide, please. I've also broken out specific prevention for youth, since I know the committee was particularly interested in what we can do to help prevent youth suicide. And so the key here, what comes up most is preventing and mitigating adverse childhood experiences. which is basically any potentially traumatic event that occurs in a child's life. It can include physical or emotional abuse, neglect, caregiver mental illness, caregiver substance abuse, household violence, things of that nature. The key here is really implementing therapy for children, implementing therapy with their families. Some of these examples are the attachment-based family therapy, which is both separate sessions for parents and children, and then joint sessions to really rebuild those bonds. Another example is the Incredible Years programs, which is a parent, teacher, child intervention to help recognize and treat behavior before a child becomes suicidal or begins thinking about suicide. And then Strengthening Families, which is another family, child, individual session plus group, but it's targeted at children from the ages of 10 to 14. And then it's also adopting social and emotional learning programs in place of exclusionary discipline, particularly in schools. So a couple of models that we have for that is the Youth Aware model, which is for older kids. It's kind of an open-ended student-led discussion to actively engage with the topic of mental health. And then for younger kids, they have what's called the Good Behavior Game, which is an approach to managing behaviors in the classroom where you have two teams and you're awarded points for good or bad behavior based on a team basis rather than an individual basis. And then, of course, it's just expanding evidence-based suicide prevention. So requiring counseling and education on restricting youth access to legal means, which includes firearms and medications and alcohol in the home, improving suicide data surveillance, suicide risk screenings. I know we are increasing with that, and I'll talk about that in some of the when we do the legislation overview, requiring in-service suicide prevention training for teachers. Many states use the Jason Flatt Act. Maryland has its own version, House Bill 920 of 2017 that passed, which has many of those similar requirements. And then important to redirect school suicide risk tip lines to primary mental health team response rather than law enforcement. And that we do have a tip line in Maryland, but you also have school violence is included in that tip line, a number of other things. So they're not going to a primary mental health team response. Next slide, please. Further with the youth suicide prevention, it's really about targeting at-risk youth, which includes juveniles in detention center, foster care, and homeless shelters, and also rural youth and LGBTQ youth. So for rural youth, it's about incorporating mental health services into primary care, but also expanding those telehealth services to make sure that you don't have less access to care just because of where you live. And then it's prevention laws about discouraging unsafe firearm storage. Since hunting is more popular in rural neighborhoods, you need to have the firearms stored such that a child can't have access, and really building those community knowledge and supports. For LGBTQ youth, you want to reduce those legal barriers to mental health treatment by revising parental consent laws, which the legislature you did this past session. Establish trainings in educational and other settings on how to create gender affirming environments and safe spaces, providing legal and policy support to make sure that transgender youth can participate in activities, and eliminate discriminatory health insurance policies. We're back to this again, making sure health insurance doesn't impact a person's ability to get treatment. Next slide, please. So a couple of states that were mentioned in the National Governor Association state strategies for averting early deaths through suicide were Colorado and Washington. Now, I will note that both Colorado and Washington have higher rates of death by suicide than Maryland, and Colorado has a rather high rate as compared to the rest of the nation, whereas Washington falls somewhere around the middle. So with that, they've really forced them to go back to the drawing board and implement comprehensive suicide prevention Colorado has a goal of reducing state deaths by suicide by 20% by the year 2024, which with a cross-sector collaborative strategy using the Zero Suicide Initiative model and targeting in subsets the youth, adults, and elderly, recognizing them as distinct communities with different needs for meeting suicide prevention. And then we have Washington, who's also doing a different model, but also comprehensive. I'm not going to go through all of those too in detail, but I do have a list of the legislative initiatives that were taken in each of these states specific to addressing suicide prevention that I can provide if anyone on the committee would like to see that. Just let me know. Next slide, please. So this is just some of the legislation that you passed during the 2021 session. We have expanding health insurance and coverage requirements and reimbursement for telehealth, particularly for mental health, requiring crisis communication to coordinate with 211 and having the opt-in mental health services phone call through 211. Next slide, please. And then targeted specifically at youth, you lowered the age of consent, which aligns with best practices, and also created the Commission on Trauma-Informed Care to really address the adverse childhood experiences, which is another best practice. Next slide, please. Two initiatives that you may not be as familiar with, I don't believe they came out of your committee, but they require the Department of Education to add adverse childhood experiences or positive childhood experience questions to the youth risk behavior survey to really identify if people are having these experiences, and SB 405, which requires higher ed institutions to actually put crisis hotline numbers directly on any identification to make sure they have access to crisis response 24 hours a day, 365 days a year. So those are some examples of really good legislation that Maryland has passed to continue moving towards best practices for suicide prevention. And I'll just turn this back over to Andrew to close us out.
Thanks, Amber. And so ultimately, what we've shown here is some of the data that's available. And even when that 2019 data comes in, or some of those preliminary data that Dr. Jones mentioned, we still aren't sure, and there will be a long tail of what the mental health impact of the pandemic has been on Marylanders and nationwide. But this is certainly something that the Department of Legislative Services and the General Assembly will continue to monitor. Thank you all for your time. I believe the Behavioral Health Systems Baltimore will be next.
Thanks, Andrew. I am next. Good afternoon, Madam Chair and members of the committee. My name is Adrienne Bridenstine. I'm the Vice President of Policy and Communications at Behavioral Health System Baltimore. Thank you for the opportunity to share with you today. I'm going to be speaking a little bit about what we are doing in Baltimore City and around the region to build out crisis care and suicide prevention. And specifically, I'll talk about the GBRICS partnership, which has already been mentioned several times, and then some two specific projects that are pilots that are specific to Baltimore. Next slide. So for those who are not familiar with Behavioral Health System Baltimore, or BHSB, we are a nonprofit that serves as the local behavioral health authority for Baltimore City. So we are those system managers that you heard Dr. Jones talking about earlier. Next slide, please. Part of our role is to serve as an extension or an arm of the State Department of Health in overseeing the public behavioral health system. And that includes the full range of prevention, early intervention, treatment, and recovery support services. A big part of our role is managing public funds and federal funds and ensuring that they are invested in services that are largely not reimbursable through that Medicaid fee-for-service system. A big area where we do invest a lot of these public funds is in suicide prevention and behavioral health crisis services. Next slide, which I will talk to you about. So as you've heard a little bit about today, one of the really, I'm going to talk a little bit more about crisis response from the system level, but one of the things I do want to mention is we know that we can prevent suicides from happening, or people even getting to that point of suicide, by making sure that we have a comprehensive, robust, community-based behavioral health crisis services, which I know this committee has been very invested in. One piece where we have been under-resourced for a very long time is behavioral health crisis services. We know that crisis care is a strategy, an effective strategy for suicide prevention. However, our crisis care system in the state of Maryland has been inconsistent and inadequate, largely, again, because it's been under-resourced for such a long time. We need to value it in the same way that we value other emergency services like our hospital, emergency rooms, fire, and police. In terms of suicide prevention and how we want to approach structuring crisis response, we need our crisis response system to have three big components. Someone to call. So you heard a little bit about behavioral health crisis hotlines. In the Baltimore City area, we have the Here to Help hotline, which is the data that Andrew presented earlier. Our Here to Help hotline gets over 40,000 calls annually. A portion of those are for people who are experiencing suicide or suicide ideation. They also need someone who can come to them or respond to them, and that's where mobile crisis teams will come into play. Mobile crisis teams are those non-law enforcement teams where it's a mental health clinician and a peer or somebody with lived experience that comes out into the community and helps to stabilize somebody, helps to de-escalate, and then also helps with that follow-up and getting somebody connected to that broader system of care. And then finally, someplace for people to go. There are sometimes where people are at a higher level of acuity in experiencing suicide ideation, and they need a place to go to stabilize, where they can be monitored by healthcare staff. So those are the three components that we think about as we look at structuring our crisis response system. In Baltimore City and across the state of Maryland, our jurisdictions have varying degrees and levels of these different components, but not nearly at the capacity that they need to be to really address the community need. Next slide. So one of the great opportunities that has become available to our state and to the Baltimore region is the HSCRC Regional Partnership Catalyst Grant Program, which you heard Tequila talk about earlier. One of the regional partnerships is the GBRICS Regional Partnership. What this project is going to do is invest roughly $45 million over the course of 5 years in behavioral health services and infrastructure, with the goal of reducing unnecessary ED use and police interaction for people who are experiencing a behavioral health crisis. The work that will happen over the next 5 years are what you see on the screen there, a couple of key elements. First, for the region, and I think I forgot to mention what the region is. The region is Baltimore City, Baltimore County, Carroll County, and Howard County. What we'll do for that region is create one regional comprehensive call center. Right now, there are 4 call centers across that 4-jurisdiction region. We're going to look to go to 4 to 1 and hopefully achieve some economies of scale there and improve the quality and response through our call center. So one regional call center that's supported with the software technology and infrastructure that call center can make referrals in real time by doing things like looking at a bed registry, being able to track referrals as they move through the system, coordinate the dispatch of mobile crisis teams using real-time GPS technology, and then finally having a robust data dashboard so we can have a better understanding of what the need is and what types of behavioral health crises people are experiencing across the region. The second component is to significantly expand those mobile crisis teams. We believe that with a significant expansion of mobile crisis teams that we can better address people's crises by having the teams come out to people in the community instead of sending law enforcement, for example. So we're going to look to expand the capacity over the course of these 5 years. Right now, across the 4 jurisdictions, we have varying levels of mobile crisis team capacity. Some operate 24/7, some do not. We're going to increase capacity so that there is 24/7 coverage. The expansion will increase the number of teams, or increase the number of by creating new teams of 30 new teams. Sorry about that, 30 new teams over the course of these 5 years, which will allow us to respond to around 55 to 60,000 more responses over the course of the year. So with that expansion, we're hoping that we can better address people's crises in the community and then get them connected to community-based care and ensure that follow-up happens, which is really important. You heard Amber talking about that earlier, that follow-up is what helps people get connected to that system of care, stay connected, and then ultimately prevents crises from happening in the future. The third component is working with our current outpatient providers so that they can offer walk-in or virtual services to help people with addressing their immediate needs. So this is a key for suicide prevention. If somebody is finding that they need to connect to their current therapist or case manager or counselor, being able to go to that person when you are experiencing suicidal ideation is really important as a suicide prevention effort. Then the third component is community engagement and outreach. We know we've got to support some culture change. Survey from Hospital Community Needs Assessment has shown us that around 13% of the residents across the region don't know how to access behavioral health services, which tells us that we need to be doing a better job of promoting awareness and how people can access services. And one of the key resources is that behavioral health hotline. We are looking forward to bringing of the new national behavioral health hotline, the 988 3-digit phone number, which is going to become the national behavioral health hotline next July. When it goes live, it is, as our view, complementary to 911, easy to remember, and it'll be the number that we're going to help to promote. And we do think that the hotline, which will be supported by that comprehensive call center, can be one of the largest access points to that broader system of care. Next slide. So two specific Baltimore City kind of specific initiatives I wanted to mention that are focused on suicide prevention is the city's 911 crisis call diversion. So this is still in its very early preliminary stages, but what it is we know that still a lot of people call 911 when they're expressing suicidal thoughts. We also know that a lot of people are calling on behalf of family members. They call 911. So we look at this as a diversion opportunity. The 911 specialists are well trained in knowing how to help people who are experiencing suicidal thoughts, but we know our Here to Help hotline, which is where our mental health counselors are much better positioned to be doing that. So we launched this pilot in the city in early June. And again, it's suicide calls specifically that come to 911 are diverted to the city's Here to Help hotline, which is our behavioral health hotline. A couple of key things, it's narrow in scope right now. They've got to be adults and they've got to be nonviolent, and there has to be no other medical concern. If any of those things exist, then a different emergency responder will need to go. Like if it's a medical concern involved, then EMS will need to respond. Sometimes we'll have a co-response with our mobile crisis team. It all kind of depends. But if none of those other factors exist, the 911 specialist will connect the caller to our Here to Help hotline in that moment, and have that warm handoff will happen. Early preliminary data as of the beginning of September, so this is really only 2 months of data, is showing that there were 290 incidents. So 290 incidents means 290 opportunities. It doesn't necessarily mean, 290 people were calling with suicidal thoughts. It doesn't mean that all of them were an opportunity for diversion. 52 of those, though, were resolved without a police or fire response, which means that our behavioral health services system, our crisis service providers, resolved that situation. Next slide. And then finally, we heard a little bit about this, but there's got to be a lot of work to continue to break the stigma related to suicide. It's still a very shameful topic for a lot of people, in particular for different subpopulations like men, in particular Black men. So one of the things that we also do is invest some of our dollars in increasing the awareness and education through awareness education about suicide. This past year, we worked with a local provider to focus suicide prevention education efforts around youth, which is another vulnerable group, and also a group that does not openly talk about suicide. So we, BHSB knows that youth don't access services in the same way as adults. They also don't talk about suicide in the same way adults do. So we partnered with a lot of trusted community leaders and partners to think through what a campaign strategy should be. We partnered specifically with an organization called Joy Baltimore, which has a lot of experience in working with youth. They are a grassroots organization in Baltimore. And they helped us to facilitate several community events throughout the months of May and June, and also helped us to disseminate what you see, we call mental health anchor boxes, but they're really like care packages to youth to help spread more information about how you can access care in the city of Baltimore, but also talking about working on to address the stigma associated with suicide. Next slide. And then finally, I feel like I can't talk about suicide prevention if I can't without mentioning our great partners at NAMI Maryland, who do suicide prevention efforts around the clock throughout the year. We partner very closely with NAMI Maryland and their local affiliates in the Baltimore area, NAMI Metro, around In Your Own Voice and some of the other initiatives you see on the screen. But suicide prevention is a key effort for them, and also a great partner in this space. So with that, that's all I have, and I'm happy to answer any questions.
Okay, with that, I will go to my list. I see Delegate Carr has his hand up.
Thank you, Madam Chair. This question is for Andrew, and it's just a question about the death statistics. So can you confirm, I'm assuming that the suicide deaths are deaths that occurred in Maryland, which would mean that they include some people that died by suicide in Maryland, but who don't live in Maryland, and that they would exclude some people who died by suicide who live in Maryland but didn't die in Maryland. They might have died in another state, but they were Maryland residents.
Thank you for the question, Delegate. I would actually have to double check the department on this, but I believe that what the Vital Statistics Administration does when they compile those reports is they actually are talking to other states and hoping to capture fatalities of Maryland residents that occurred elsewhere. And so the numbers that we're presenting should be representative of Maryland residents and not necessarily Maryland incidents. But I would be happy to double check on that, or if the department knows offhand, but that is my understanding of the data.
That's my understanding as well.
Thank you.
Okay, Delegate Lewis Young. I'm sorry, I missed Delegate Hill. Let's go to Delegate Hill first.
Thank you, Madam Chairman. This is for Ms. Bridenstine. I think your group work is focused on suicide, but other crises calls may come in and you try to divert those as well or handle those. Could you address a question I had to the other panel? How are you going about, it seems that you're effectively doing it, making sure you have adequate providers in the community to do this, to do the handoffs to? What are the tricks that you're using in this provider crisis that we are to make sure that you have people who can take care of these folks as you bring them down?
Thank you for the question, Delegate Hill. So we are not immune actually to the provider crisis. One of the things that gives us incredible heartburn and concern is, I said we were going to expand mobile crisis teams. We are worried that we won't have the workforce to expand it as much as we would like to. The workforce crisis is impacting our behavioral health system in a variety of ways, including our crisis providers. One of the things that we do to ensure that we've got adequate and quality providers is we do competitive procurements to identify the providers that offer or that are going to provide the services. So we have done that for our crisis services. We will do a competitive procurement for as we expand mobile crisis teams to identify those providers. But again, it's still going to be a challenge to identify the workers to expand those services.
And to clarify, you're talking both the acute and the handoff, the follow-up care.
Mm-hmm.
Yes. Thank you, Madam Chair, and thank you.
Thank you. Now, Delegate Lewis Young.
Thank you, Madam Chair. I think I want to address this question to Adrian because you brought up 988. the suicide hotline that will go into effect next July. Since there is an anticipated increase in call volumes, how will our call centers be compensated for that? I've already been alerted by one of my local call centers that they're only being compensated $7,500 a year for 211, which doesn't begin to cover their costs. So they're very concerned as they look forward to taking on 988 calls, how they'll be able to finance that.
So that's an area that we are also looking at and are concerned about as well. Right now, the hotline the Here to Help hotline in Baltimore City is grant funded with state and federal block grant dollars. The GBRICS partnership will add on top of that, right? So we're going to be investing several $1 million starting next year to create that regional call center. So we have funding. Theoretically, we have funding for our regional call center for the next 4 years through that HSCRC Regional Partnership Catalyst Grant, but we have got to find a way to sustain that. So we are going to partner with the HSCRC and MDH to figure out what a sustainable funding model is. But there is an opportunity through 988 that has become available to states to create a 988 fund. Which would create sustainable funding for call centers, but also for a continuum of crisis services.
Thank you very much. I have an idea. I'll get in touch with you offline.
Great. Look forward to it.
Thanks.
Thank you, Delegate Lewis-Young. We'll now turn to Delegate Cullison, followed by Delegate Johnson.
Thank you, Madam Chairman. This question I'd like to address to Dr. Jones, and I think it sort of relates to what Delegate Lewis-Young was just speaking about. And as I said earlier in the meeting today, I'm really interested in making sure that all of our resources are used to provide maximum services. 211 Press 1, which the state invested in 2019, has done a pretty good job of, I would say great, but I'm prejudiced, of helping folks to find the right services that they need. They've got 5 call centers. So how do you anticipate 988 intersecting with 211 and coordinating with them so that we are, number one, recognizing these resources, but number 2, building on them?
Thank you so much for that question. Very good question. And we're trying to make that determination now. We're very proud of the work that we've done with the 211 Press 1 system. And we recognize the mandate to move to 988. However, we're trying to figure out the best way to integrate it so that we don't lose the functionality that we have and the local responsiveness that we have with the 211 Press 1 system that currently does not exist with the 988 system. Mm-hmm. There's some challenges there. We had a report that we are and a whole team that's working on this effort, and we will continue to try to figure it out up until we have to make that transition, including how it is that we're going to fund it as well. That's a big part of the work that we're doing and working with the overall department to help figure that out as well.
Okay. Well, if there's anything I can do to help, please let me know.
Thanks. We appreciate that. Thank you.
Delegate Johnson, followed by Delegate Krebs.
Thank you, Madam Chairman. My question is kind of an expansion on some questions that have already been asked, but using Dr. Jones' presentation, the numbers in her presentation, from January through June, and I used the 2019 numbers. If we continue to do nothing until we get this program built out over the next 5 years, we will have an additional 1,215 suicides and an additional 46,000 attempts. So how do we use some of the funding that we have available now to work with the centers we have available now until we find a sustainable funding source? You know, how do we step up our game now with some of the funding that we have available?
So, so the bed registry and referral tool and the conversation about what's happening with suicides, though there may be some overlap, there's not. I don't think there's the overlap that that you're referring to. Our efforts to address and combat suicide are longstanding and have been for many years in the state of Maryland, and we only continue to expand upon them, to bring more resources to bear, to partner better with other state agencies and including school districts, to leverage the federal resources, to look at how we're managing crises, period, regardless of the call line that you might use to report the crisis, but what do you do when someone is in a crisis? So we're taking a multi-pronged approach that's not, that really is separate from the referral process and having this, the bed registry issue is not really, is not in any way impeding upon our efforts to continue to expand outreach for those who might be at risk for suicide.
And I appreciate the answer, and it sounds good, and I stand 100% behind expanding the access to care. However, I just don't hear a sound plan, because we have functions now that are struggling because of funding. So when we talk about expanding, I would just like to hear a more comprehensive plan on how we expand when we really can't keep up with the funding of what we have available at the moment.
Well, certainly if we have providers that are having challenges, they are certainly always welcome to reach out to the Behavioral Health Administration. They do on a regular basis to let us know. And if we have resources that we can avail for dollars that we have not needed to spend in other areas, we're certainly open to have those conversations, and also looking at other local resources as well, and also looking at when do we have additional resources that are coming to bear. But no one has reached out to us to say that they are having specific challenges in their ability to implement programming that we need to address suicidality in the state of Maryland.
And what department do they reach out to? Because I have in my district, the Klein's Crisis Center, that I can tell you they're having issues. So who do they reach out to, and how do they know to reach out?
So we have an active relationship with the Klein Center. We fund them. We give them several $1 million every year for the implementation and to support implementation of their programming. And we recently gave them dollars through relief funding. So Klein knows how to reach out to us. They have they have a really great program that we are very fond of. We think they provide excellent care. But we are concerned about their sustainability just as well as they're concerned about their sustainability. And that's the challenge with crisis services being largely grant funded as opposed to being reimbursed in another format that does present challenges. And so that's why we have a crisis services work group in the state of Maryland that we have been working together since the beginning of the year, February. Actually, internally, we started coming together back in August of 2020 to look at a comprehensive plan for crisis services for the entire state. And then in February, we formed a work group of a multi-stakeholder work group that includes a finance subcommittee. The finance subcommittee has members on it from Maryland Medicaid, HSCRC, BHA, on the operational command, Opioid Operational Command Center. We're all working together to try to figure out how do we create a sustainable model for funding of Maryland's crisis services system so it's not dependent upon grant dollars that come and go. So yes.
Well, thank you, Dr. Jones, because I think you just substantiated my question. There you have an organization that does great work but they're struggling. And they're in existence now. So I appreciate your answer. Thank you.
You're very welcome.
Oh, I can't hear you, Madam Chair, but I think I'm up. I just want to follow up on what some of my colleagues have talked about with coordination of efforts. As you all know, I serve on the Next Generation 911 Commission, and we first started off about upgrading 911, but now we've delved into diverting calls from 911 to get to 211, and now we're talking about 311. And Delegate Hill is now on the commission as well. But Adrian, I wanted to sort of address this to you because it came to my attention through GBRICS, and I want to divert for a minute about GBRICS. I mean, I really believe that this problem that we're trying to solve is going to happen from the local community up, like you're doing with GBRICS, versus from the state down. And what we're doing with these pilot programs, really, in HSCRC, I think the pilot programs in these areas are just the way to solve the problem, because every area is different. And I'm very impressed with what's going on so far with GBRICS and who you've brought to the table and what you're doing. But it came to my attention when we had a briefing, I guess I had a briefing with you guys earlier this summer with GBRICS about the 988 versus 211, and now we've got 311. And I want to just tell everyone on this call today, we need to look back at legislation that we've passed, because you talked about Senate Bill 405 requires higher ed to provide telephone numbers of helplines. We need to do this sooner than later, get this helpline issue resolved, because we've got 211, we got 988, which is federally required from what you guys have told us, that we've got to use 988 for federal funding. 211 is in place. It's been great. Delegate Collison's been the focus of this, and it's a great opportunity to have these call centers for crisis. But we need a coordination of efforts, and we need to come to some conclusion sooner than later. Because I had a meeting with our county yesterday, and I was telling them, updating them on all of these things with our county local officials. And I don't even want to say yet, do you call 911? Do you call 211? Do you call 988? Do you call 311? And we've got to get it resolved, and we need to do certain things well versus doing too many things at once. So I know that you guys are on that. And I know it sounds like Department of Health, but I'm just suggesting, Mrs. Jones, that you come to some conclusion sooner than later, and we don't have all these helplines out there. And nobody knows which ones to call, because it's right now it's in limbo, and our group needs some direction on it as well. Because we've had the executive director for 211 is part of our group and has been part of the Next Generation 911 group. And I mean, he's concerned too, because he's moving forward with their efforts. So I'm just asking for Adrian and also Department of Health to please come to some resolution on this and make sure that our laws that we've written already have some coordination of efforts. We got a lot of effort going on. It's all good effort, but we've got to coordinate these efforts in order to get it out to the public, because I don't want to put it out there and then it change. So, and I even know United Way is pushing the 211 number, which is great. But if we're going to switch next week to 988, we need to have that conversation today. And I want to thank Adrian and GBRICS. I really think this is going to be a great pilot program, and we appreciate what's going on. So that's a question, that food for thought and a statement, and you don't really have to answer, but just please commit to doing this sooner than later.
Yes, I can tell you from the local level, we can commit to that. And you're absolutely right. It is complicated to coordinate them. It makes my head spin a little bit, but we know at the least for the GBRICS region that we will be able to, through the routing with 211 and with 988, we will be able to coordinate that.
So if I called 988 today, would it work?
Yes, you would call a different number today. It would be a 1-800 number, but you would get, depending on where you're calling from, you would be answered by one of Maryland's 8 already existing Lifeline providers.
Okay. Well, I would just like for us all to understand better what exactly we should be doing today in the plan. Thank you.
Okay, I'm going to ask for a little clarification, because that answer confused me. You said if you called 988, you would be calling from a different number, a 1-800 number. I don't know what that meant. Did I dial 988 and I got shunted, or was I supposed to know that 800 number?
So can I answer that, Adrian?
Please.
So if you were to dial, so the transition to 988, that's the cell phone carriers some of them are making that transition now. So if you were to call 988 now from your cell phone, it will take you to the National Suicide Prevention Hotline, The National Suicide Prevention Hotlines are also are also answering 211 press 1 calls. So all the calls are going to the same place right now as it stands. So if you were to call the 1-800 Lifeline or 1-800-SUICIDE, if you were to call 988, if you were to call 211 press 1, you're going to get routed to the same place. The department, when we get closer to knowing that the 988 system is going to be able to manage the calls the way that the department expects the calls to be managed, then we will have a full out media campaign to make sure that the public is very well aware that we have made this transition to 988. Most states are not rolling that out until next summer. That's when it's required because there's a lot of steps that have to be taken for the processes of integration. So that will not likely happen until next summer.
Thank you. That was a very clear answer. Even I could understand that. Thank you all for your participation today. We appreciate the contributors and the members. I'm always grateful for your wise questions to help us understand things. With that, this briefing is ended.